keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, my name is Vasken Dilsizian. I'm Associate Editor of JACC Imaging. With me in the studio is Dr. Gewirtz, who's Associate Professor at Harvard Medical School and Director of Nuclear Cardiology at Massachusetts General Hospital in Boston. Henry, welcome.
Thank you for having me.
You have a paper in the current issue of JACC Imaging where you looked at exercise-induced ST segment elevation as an indicator of ostial LAD or left main stenosis. We found it very interesting because at least most of us look at the aVR lead as the no man's land lead, and we don't really pay attention to it much. And any changes in the aVR, we tend to think that it would be reciprocal changes compared to the other leads. Perhaps you can tell us why aVR?
Well, it's been known for some time that the lead monitors intercavitary potential, and so it's capable of looking from the apex to the base of the heart from inside the heart. And so septal ischemia in particular is viewed as an injury current, and so its sensitivity for detecting ischemia in that territory is well documented in the literature and well known electrophysiologically.
So I take it that the basis of your study in looking at exercise-induced ST segment elevation was based on the acute coronary syndrome patients in the literature?
There are reports of that, as you're no doubt aware, but there also have been reports over the years of stress test-induced ST elevation in non-ACS patients, and we had seen a few cases anecdotally and decided to look at it more formally.
Okay, so could you briefly tell us how many patients you studied and what did you find?
So this was a retrospective analysis, and search criterion ultimately included 454 patients, of which roughly 75 or so had left main or ostial. There were another 200 odd who had, almost 300, who had 1, 2, or 3 VD, but not left main, and then there were 100 normal cases.
So, if we were to apply this clinically, then what did you find as far as sensitivity and specificity and accuracy of using aVR? First, I guess, as identifying left main ostial LAD, and or overall coronary artery disease burden.
So the principal objective, as you point out, was the left main and ostial LAD. And there the sense was 75%, SPES was at 81%, overall predictive accuracy was at 80%, and that was by virtue of having 94% negative predictive accuracy and 44% positive predictive accuracy. And that was limiting the exercise to identification of left main or ostial LAD. If you looked at any coronary disease, which we did not formally attempt to do, well, I shouldn't say that. We did do that, but we didn't put the data together that way. We did find that variously 15, 25, and 40% of 1, 2, and 3 VD patients who did not have left main had ST elevation in aVR with stress.
Great. So now, when we look back at some of the publications that say the global risk assessment of coronary cardiac events, among the patients, I think there were 2,400 patients who underwent cardiac catheterization. The prevalence of left main or 3-vessel disease, not just ostial LAD, in that registry was 56%. Realizing that they're not the same patient population, perhaps it's worthwhile to discuss what are some of the other conditions, that is false positive and false negative for aVR. For example, pulmonary embolism, pericarditis, are those type of things we should be paying attention to? And they don't present in the chronic setting, obviously. They usually present more with acute chest pain. But should we be worried about non-specific STS segment elevation?
Well, I guess the test isn't perfect, so going forward, the chance that the test will be truly positive for left main runs at 44%. On the other hand, the incidence of that disease in the population that we studied was only 17%. So looked at in that way, the risk is tripled by virtue of having ST elevation in lead aVR. Pericarditis is often a contraindication to stress testing and is manifest with diffuse disease, as you know, and an aVR PR depression, which is something that we didn't observe in this study.
Sure. And now what about myocardial perfusion imaging?
Yes.
What did you find, and what is the incremental value? Should we be paying attention to both EKG leads and perfusion imaging, or should one trump the other?
Yeah, we definitely found that the ejection fraction, which is obtained after stress in our institution, correlated inversely, so it was a univariate and multivariate predictor, as was the extent of LAD reversible ischemia. So there's no doubt that the myocardial perfusion imaging, typically with SPECT MIBI, but thallium works, of course, as you're very well aware, is important and does add value. When you do the formal statistical analysis, the AUCs differ significantly, and the AUC on aVR is 0.82. That for the imaging signs is 0.62, and those differences are significant.
That's great. So if I could summarize, Dr. Gewirtz, your paper highlights the relevance of looking at the lead aVR beyond simply looking at perfusion imaging. And in the cases of whether you have a normal perfusion study and elevated aVR, or lack of aVR elevation but reversible LAD perfusion defect, the goal would be to add these two data points together, since neither one of them are 100% accurate, and perhaps we can identify most left main and the critical osteal LAD lesion. Would that be
a fair
summary?
I think that's reasonable, and I think as the paper shows, there's no doubt that you can have ST elevation without any of the typical imaging signs. In fact, scans that most experts would read as normal. So it's very important to look at the whole patient and all the data.
Dr. Gewirtz, it's been a pleasure for joining us, and please do read the current JACC imaging issue to get more detail of these very important paper. Thank you for being with us.
Thank you very much for having me. Appreciate it.